Well, hello and welcome to On Second Street's special in-depth discussion with Alberta Premier Danielle Smith. This is part two. In the first part, we talked with the Premier about how really in this country, we find a system in crisis. It doesn't matter which party is in power, but yet in Alberta, the Premier is really trying to move the system closer towards European models, making some big changes. We've definitely enjoyed the first part, and today with Premier Smith, we're going to be talking about a recent trip that she made to Sweden, as well as some changes that she's making on preventative care and maybe some other issues too. So without further ado, thank you, Premier Smith, for taking a few minutes again to chat with us about it. I mean, obviously, healthcare is a huge, very important issue. I mentioned off the top that you're trying to move the system closer towards European models, and I understand you just got back from Sweden. Could you tell us a little bit about maybe some of the lessons learned from your trip to Sweden?
Well, I know you've been to Sweden, and I think you've talked to some of the same people that we did. But one of the reasons Sweden interests me so much is I think most people look at those Scandinavian countries as having been the inspiration for Canada's own Health Act and how we approach universal coverage. But the interesting thing is that Sweden got into some financial trouble somewhere around the early 90s. And so they started looking at new ways of delivering a universal system. And it feels like Canada kind of got frozen in place and didn't start looking towards what some of those innovations are. And so that's what I wanted to do. I wanted to do a check in on a system that's built very much like ours, but has really explored more of the two things that I think have been really important to our system is separating out the purchaser and the provider and the evaluator. Those have to be three different functions, but also allowing for competitive delivery of all types. So having private, having not for profit, and having, of course, publicly run as well. And to learn some of the things that we should be looking at that we can adopt out of best practice, based on the fact that they've had now a couple of decades head start on us and on looking at these innovations.
Well, let's dig into it. Were there any, like I take it you probably toured like maybe a private or public hospital. Was that part of the tour, or was it just talking with more sort of officials and experts?
Well, I talked to a group called Synapse, which is a health policy think tank, and they had
Yeah.
a person who represent a CEO who represents one of the large healthcare providers who's private, and then we also met in a boardroom with another large private healthcare provider. So the names of those are Alaris and Capio. So we got to see a little bit about how their business models are and how different they are. And I would say Capio in particular was of interest to me because they run a full service private hospital, which is something that is unique from a Canadian perspective. I don't think Canada has any full service private hospitals. We've got a number of surgical clinics, and we've got a number of clinics that would provide a range of services. But having a hospital that also provides that emergency care, that would be kind of unusual. And so I wanted to understand a little bit about how they do their work. And then we visited the Karolinska Hospital, which is a full service public hospital. But the interesting part about them is they actually don't have a walk-in emergency center. You can only get to the Karolinska Public Hospital by referral because they are an academic and teaching hospital, and they only deal with the most complex cases. So that kind of flipped it on its head, the way I was thinking of what I would find there, because that's of course a model that's very different to ours. And so, what is the distinction of having two hospitals that operate that way? Well, a very different funding model. I think last time you and I spoke about activity-based funding. And what was quite interesting is that in the private hospital, they have a very small share of their budget that's fixed. We call that a global budget because we give
Yeah.
100% of our budget is given as a dedicated lump sum. So they have 15% of their budget as a dedicated lump sum. That's meant to keep the lights on, make sure the insurance is paid, pay for sort of the base staff that you need to run the basic functions of the hospital, and then 85% is activity based. They get paid based on the services that they provide, and they have a very sophisticated funding model. So they're not billing for every Q-tip, and they're not billing for every scan. They kind of have a lump sum that you'd expect to pay for a particular procedure, and you have to be able to provide the service within that lump sum. And if your costs go over, you have to eat the cost, and if you end up coming in a little bit under, you get to keep that as the benefit. And so I thought that's kind of an interesting way of looking at the activity-based funding approach. Then you go over to the Karolinska Hospital, and I hope I have my percentages right, but it's the reverse. 70% of the Karolinska Research Hospital is a fixed budget because they're bringing in researchers. They've got their doctors who are on salary, and they, of course, would then be doing all of the additional academic work that is non-clinical, and then about 20% for research, and only 10% is activity-based. And so what that showed me is that when you are the purchaser, you can actually create a funding model for each of your providers that actually makes sense based on the services that they're providing. And so you have the ability within a publicly funded system that has a number of different service providers to have that kind of tailored approach. And it also results in different ways of supporting the doctors in the way they want to work. So you could imagine what kind of doctor would want to be paid on an activity basis? Well, that's probably somebody who's doing a high volume of surgeries like cataracts, knees, hips, and they want to be rewarded if they're able to treat more patients and do more services. What kind of doctor would want to be compensated on salary? Well, somebody at a research hospital, they're motivated for a different reason. And I asked the doctor about that because when we found out how much they got paid, my jaw dropped. So they got paid about a typical amount of 7,500 euros a month, which works out to about 90,000 euros a year. And doing the math on that, that's about 150,000 Canadian. We're accustomed in our system to doctors making anywhere between 450 and 600,000 on average. And so it was quite a difference in the amount of pay. I said, well, why would you be willing to work for such a low rate of pay? And it was because they get to come to work and do interesting things every day. They said that if I worked in a different hospital, it might be that I only see a unique or strange case once every so often. But at the Karolinska Hospital, they're seeing unique and interesting cases every single day. So the academic stimulation, the intellectual stimulation, that was one of the things that they looked for in the job. So that I think is something for us to remember, is that doctors are just like the rest of us. People are motivated to have a job for different reasons, and we have to create enough flexibility in our work environment that we're able to accommodate both. So I thought that the interesting difference between the two of them was surprising to me. And so now that I've described Karolinska, now you can understand why they don't have just a walk-in emergency room. Because if they're only dealing with the most complicated specialty cases, you have to have a referral to be able to go over there. And that's part of the reason why they do it a little bit differently as well. So those two different models are something for us to take pause on, because we're about to implement activity-based funding. And we have to figure out what are those correct percentages. What is the percentage of a hospital that needs to be fixed and covered so that they don't have to worry about keeping the lights on? And what percentage of the procedures and services that they provide can be activity-based? And I think we'll get some good advice from what we saw in the Swedish model.
Well, that's great. I actually put on LinkedIn, I saw your post, I shared. I said, we need to see more politicians in this country. It doesn't matter what political party doing this, going to these better performing countries, taking a notepad and writing down what they're doing differently, because so many of these European countries are providing what Canadians want, right? A universal system, everyone's covered. You're getting quality treatment fairly quickly, and you're not facing a major bill when you walk out the door. So good on you for doing that. I wonder,
Well, and
just
let me
in
talk.
terms.
Do you want me to tell you about a few more things? Because I did. It's funny you should say that, because
Sure,
I
yeah,
happened to
yeah.
be on a healthcare call with back home while I was over there, and able to share some of
Okay.
the other observations that I got, because we're dealing with a really difficult issue at two of our facilities. The Sheldon Schumer Center is one, but Royal Alex in Edmonton in particular, that we find that there's a large homeless population that is repeatedly going back to these facilities. and using a very large number of services. I think we quantified it at the Royal Alex. We have 606 people who are regular users of Royal Alex and the other hospitals, and they're responsible for 20,000 visits a year. And then when we look at all of the high use patients, somewhere around 2,800 of them, they're responsible for over 80,000 hospital visits a year. So I asked what they did. I met with the Swedish Association of Local Authorities. So they actually have a local authorities that does the nursing negotiations on a regional basis. I asked them what they do with this problem of homeless people, and they said, "What do you mean? Why would homeless people go to a hospital? It didn't make sense for them." I said, "Well, we have homeless people who sometimes sleep in the ambulance bay at the Royal Alex," and it was like I'd grown three heads. They didn't understand what I was even talking about. They said, "Well, why would they go there?" I said, "Well, the nurses give them sandwiches." And you could see that there was just such a different mindset that hospitals are hospitals. They're not homeless shelters. They're not mental health and addiction places either. There's different places for that as well. Hospitals are a place for emergencies to take place. You get somebody in, you stabilize their treatment, and you get them back into the community as quickly as possible. So there were a few different things stemming from that. One was, how do you enforce that? How do you get people to only stay in hospital for the time that they need to be for the urgent care? And it's an expectation that these emergency hospitals would only have a patient in their premises for about 3 days. And then they would go and convalesce somewhere else, normally at home. So I'll talk about that in a second. And then they also have geriatric hospitals, is the term that Capio used. And that's where, in flu season, somebody who's a senior needs to go to hospital to get stabilized, because as you get older, your immune system is not able to fight off those flus quite as easily as when you're younger, or if you've fallen and broken a hip, or if you need nutrition and you need to be on some kind of drip. Rather than going to a hospital, you'd go to a geriatric hospital, which might have a 6-day length of stay, but it's almost more of a convalescence facility of specialized support. And then they have a final thing called hospital at home. They talked about that quite a bit. The regions I was talking about said they had as many as 4,000 beds for hospital at home. Keep in mind, so Sweden's about double our population. So imagine if that same thing applied in Alberta. Imagine if we had 2,500 or so hospital at home beds. And it's beyond home care, because home care is mostly either private aides or nursing aides that are providing sort of basic care. This would be a much higher trained individual who's able to administer chemotherapy at home and dialysis at home, and some of the other types of things that you would just be convalescing in a hospital. And you get a real sense that, why would we want to keep people in hospitals? It's a dangerous place for people to be, because they can end up deteriorating in their condition the longer they're there. And people are far more comfortable at home, so let's support them at home. And when it comes to how do you enforce it, well, everybody is attached to what sounds a bit like a primary care network. We have those. I don't think they're working quite as they should, because not everybody is attached to one. But what happens is, if your client is in hospital longer than the recommended length of stay, you get charged $1,000 a day for every day that they're in hospital. So then what happens is, the primary care network is working to try to figure out, what is a hospital at home solution, or how can we do the recuperation at home, in order to, because they'd be able to provide the services in that environment a heck of a lot for a heck of a lot less than $1,000 a day. So they just have some really interesting financial mechanisms that they use to try to make sure that the patient is getting the right care in the right place, that we haven't even begun to explore in Canada. But it seemed to me, as we were talking it through, they were sort of astonished that we hadn't explored some of those things as well, and that we were experiencing some of the problems that we were. So I would say that those are some really interesting innovations that I think we need to look at. The other thing I would say is, at Karolinska Hospital, we met with the CEO. So think about that, having a CEO at the helm of each one of our major hospitals. That is local decision making in action. He happened to be a pediatrician by training, but clearly he had a great understanding of all of the financial aspects of running his hospital. And when we've said that we're moving towards more local decision making, that's what we need as well. We need to have those who are in those senior roles managing the hospital have a acumen so that they can start managing and looking for the kind of opportunities that I've just described here. So that is going to be one of the other aspects that we're building out over the course of our reforms.
I think that's an interesting point about local decision-making power. We kind of had an aha moment in France when we got outside of Paris to a government-run hospital, is extremely well respected in the nation. And they talked about some of the changes they were making structurally to the hospital because they had the authority to do it. And under an activity-based funding model, they had some funds that they could access without having to write to the minister to say, hey, we want to take some of these walls down or whatever it was. So I
Completely.
think that
It
there's certainly a value when you empower people at the local level because they often know what needs to be done, right?
it has driven me crazy, these stories that I hear about the lack of authority at the local level. Going back to when I was in politics the first time in 2012, and sadly seeing that the problems had just gotten worse rather than better in the time I'd been out of politics. But people not being able
Yeah.
to change light bulbs in the emergency room without calling in central authority to do it. Uh, People not being able to order additional chairs in the emergency room without going through central procurement and taking months to deliver, not being able to do laundry on site, and so having to send it 3 hours away, and the folks in the hospital losing hearing aids or dentures as a result of that. The story of not being able to buy a bottle of bleach from the local hardware store. I mean, these are the
Wow.
things that leave people feeling very disempowered and frustrated. Those are the small decisions that we haven't allowed local decision makers to make, but they should be making big decisions too. They should be able to enforce that you can't have somebody coming into hospital and languishing for weeks or months or literally years without having some accountability to move them to a more appropriate space. That there has to be local decision makers who have the authority to find the appropriate place to move those patients onto, and that's one of the big things that's been missing in our system, and that's one of the things that we're working on filling the gap on.
Yeah, no, I agree. It's not even just unique to healthcare. You need people often feel better about themselves and where they're working. They're happier when they have a sense of empowerment. It doesn't matter if it's healthcare or education or you're off working in a widget factory, right? People like that sense of ownership. I want to switch gears a little bit. I want to segue to some of the reforms you're making with preventative care, but I'll just mention an example from Sweden because I'm not sure if it maybe came up in your discussions, but there they have something called physical activity on prescription, where one official that we talked to, he was a doctor, he said that sometimes doctors are even compensated a little bit more to do this. But if a patient comes in and the doctor assesses them and they're looking at their situation and concludes that, well, this patient needs a bit more exercise in their life, the Swedish government will actually work with that patient to, one, not only prescribe exercise instead of just, here's some pills or, surgery or whatever, but to encourage them to exercise more. And in some cases, they'll actually help them develop a plan. Did any of the preventative care come up in your discussions with Swedish officials?
Well, you've given me reason to go back again because that one did not come up. But I think part of it was that
Yeah,
our focus really was on how do they get their hospital care working so that we can get some advice on how to get ours working better. But you raised such a good point because when we went to the local authorities meeting, they were talking about how dental care for kids under the age of 19 is covered, and it got me thinking because I was wondering why is it that the amount that Sweden spends on a per capita basis is the same as the amount that we spend on a per capita basis. They're actually a slightly higher. Their number of hospital beds, I think, are actually slightly lower than ours because they don't, for the reasons I described, do not have every sort of a model of everybody has to go through the door of a hospital in order to get treatment. But what it shows you is that when you can find more efficient ways to deliver on your hospital system, you can expand your programming and what you cover to include other things, right? So that kids under the age of 19 develop good dental care, which is important for a lifetime of care. Or you can have your doctors focused on writing exercise plans so that you can end up avoiding the hospital altogether. And so we've developed a system that is so focused on getting somebody into a hospital door and into a hospital bed, which is the most expensive level of care, that it crowds out some of the other ways in which we could avoid that door in the first place. And this is why we created the Ministry of Health and Primary Care and Preventative Health, is because we know that that is going to be an essential way of creating a new door for people to go through. I should mention I'm very enthusiastic about this. There's a wonderful program that I just discovered called Apple, and it's not Apple, the tech company. It's Apple, the wellness company, and they're in about 40 of our schools. And they have a model where they teach student leaders about good nutrition, getting exercise on a regular basis, doing meditation for calmness and mental health, and getting a good night's sleep. And then as the kids go through the program, they start leading the younger kids and teaching them all of these things. And you can only imagine the kind of pay it forward that's going to have for those young people to be exposed to those ideas at such an early age. And if it's good enough in that environment, it's kind of a no-brainer that kind of approach should be taken across our primary and preventative healthcare system. So one more thing for me to bookmark and go back to Sweden for, but it's pretty clear to me that there's almost a limitless amount of money that could be spent on healthcare, because there's nothing more important than that people care about than their own health. And if you can find a way to be efficient, it just allows you to take better care of people. That was sort of one of my big takeaways from Sweden. Everywhere that I did go, I did not experience or hear about the kind of chaos that I often hear about within the hospitals that have become so overburdened with too many patients going through the door, many of whom should be going through another door, not going through that door altogether, or getting their treatment and care somewhere else. And so, if we can just create a few more of the different pathways that we see in some of these other universal systems, I think it's just going to result in a better experience for everyone.
I think you're right. There's so much to learn when you go abroad. Like I said, I'm glad you do this because we need to see elected officials do more of this. Let's talk about, we've got about 6 minutes here, but let's talk about what you're doing in preventative care with diagnostic
Mhm.
scans, because I think that's interesting. So much we're always worried about, like you say, how you deal with the patient once they're in the system, but it's so much better if we can catch problems earlier on. Could you tell us a little bit about that change?
Yeah, I think last time we spoke, I talked about my inspiration hearing from Tokyo and Seoul, Korea, about how these private full service testing clinics create almost like a peace of mind test, or it's almost even like an annual physical on steroids because they really put you through the ringer,
Yeah.
and so that you can get tested on everything, on all of your fluids, on your ECG, chest X-ray, and ultrasounds, and also an add-on for CT scans and MRIs if you think you need that extra level of diagnosis. But but because they have such a high volume of patients going through this, because it's basically everybody goes through it on a biannual basis. Annual if they want to pay, if they have an employer who will pay for it. But it's brought the cost of these scans down to $500 to $700 a year. And if you can find something, then you're able to get into treatment faster. And that's something that we should all be waiting for. That you shouldn't have a punishing process to try to get to a diagnosis when you just know something's not right with you. It'd be better to go in, get everything checked at once, identify quickly where the problem might be, and then get in to see a specialist faster. We feel that if you take this kind of approach, the main things that I hope we're able to get an early diagnosis on would be cancers, because we know that if you can get a cancer diagnosis way earlier, you just have better treatment options that have less long-term harms, but are also more likely to be successful. And I think the example I shared with you about last week was an individual who went through it and discovered he had leukemia, so he was able to get into treatment for cancer by going through that system. And so I think what I would say that is so different about our system is that we either get over tested, So we're fine, but it's test after test after test that gets ordered, or we undertest, and people feel, no, I still haven't quite found what it is, but they may not be able to get the direction to get a test, and so having a full service testing center where you can walk out with some peace of mind. Yeah, they checked me all out, and they found this little thing that I can now go and get checked, or they found nothing wrong with me, and then you're able to even get baselines and go back each year or every couple of years. In some ways, when you've experienced that or you've seen that in action, you say, why wouldn't we do it that way? Why wouldn't we make that more
Yeah.
available? So we want to get it started because in some ways, having the private sector take the lead on it to identify the kind of services that people might want. We think that that is probably a good way to let free enterprise take the lead. And then as they start developing them, then we can see whether private insurance plans are going to cover them. It allows us as government, remember, we're a private insurer for a lot of our employees, for we have a seniors coverage as well. We cover for AISH. Once these things have developed, perhaps that's one of the things that we would also look at covering for for those that we cover. But you've got to get started somewhere. And if the public system with their monopoly that they've had a privilege of for many years, if they haven't developed this kind of approach, that says to me they're never going to. And so now we need to let the entrepreneurs get in there and see if they can develop an approach that's going to work better.
Yeah, no, I think it's really interesting. One of the things I like about it is that you're freeing up doctors' time. Correct me if I'm wrong with any of this, but as far as I understand it, you're freeing up doctors' time because if I have a family history of, say, cancer in a particular area and I want to get it checked out regularly, well, I either depend on the public system, and obviously sometimes that can take a long time, or if I want to pay privately, I have to go to a doctor every year, or however often I do this, and get the referral. So now,
Yeah,
as far as I understand, I can go straight and pay without tying up that doctor's time to say, okay, here's a referral. And now that doctor can help
completely.
someone else when I'm trying to just, keep an eye on my own health and prevent something.
Completely. So there's a few things I'd
Yeah.
say about that is that what happens at these testing centers is that they do have a doctor on site. So they have the various technicians who run through the program, and then at the end there's a doctor on site who will just say, "Hey, already from what I'm seeing, I'm going to flag this, this, and this, and this for you." In Japan,
Yeah.
my understanding is that you then are able to get a referral directly to the specialist, and so you don't even need to go back to your primary care practitioner. And so that again, being able to get something diagnosed and then get in right away, that'll ease a lot of frustration for people. The important part of what we're proposing is that if somebody if someone if one of these diagnostic tests finds something gravely wrong with you, like cancer, we'll reimburse the cost of the test because we want people to take advantage of these options, identify if they've got something gravely wrong with them, and get them for treatment. That's what it's all about.
Yeah, well, it's very interesting. It'll be interesting to see how that one rolls out. We've got to wrap it up here, unfortunately, but as always, thank you for taking the time to talk about this really important subject and some of the changes you're making.
We'll do it again.